Greetings, hello and welcome. I'm Steve Clemens, contributing editor for The Hill. Thanks so much for joining us today for our program, Closing the Gaps in Health Insurance. Before we begin, I'd like to thank our sponsor, Consumers for Quality Care, for their support of today's discussions. Listen, a record number of Americans are insured, with over 90% of people having some form of health insurance. You might think that's a good thing, but listen, many insured Americans remain vulnerable to significant medical expenses, including high premiums, out-of-pocket costs, prior authorization burdens. You get it. How can we address rising medical costs and accessibility issues that a lot of these insured Americans face? What policy changes are needed to improve affordability across the healthcare landscape and ensure that the pursuit of care doesn't jeopardize their financial stability? Ultimately, how do we build a healthcare system that works better for its patients? That's really the key issue. We're going to be putting these questions and more in front of our fantastic lineup of speakers. But first, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillHealth. We're broadcasting live and we'll take your questions throughout the program. We already have some really good ones. And as with any live stream, you could experience occasional trouble with the video. I laugh at this because please do not throw your computer or screen through the window. Refresh the page and that should fix all the problems. Congressman David Schweikert of Arizona sits on the Ways and Means Committee, and he's a senior House Republican on the Joint Economic Committee. I spoke with him just a short while ago. Take a listen.
Congressman, it's so great to be with you this morning. I've always enjoyed our conversations, and I want to tell our audience that Dave Schweikert is the lead Republican on one of my favorite committees in Congress that has no power, no votes, but it is about raising the quality of thinking about economic policy and about our thinking. That's Joint Economic Committee. I love the work of the Joint Economic Committee. That said, here we're to talk today about what the health ecosystem is generating in terms of outcomes on health, but when you get to the kind of the cost dimension, I sometimes feel like we have to have a very kind of interesting rat maze to figure out how to optimize this healthcare system. But as we think about costs of healthcare today and getting more coverage for Americans and better quality healthcare, where are we screwing up?
Pretty much everywhere. Okay, can I first give you just a simple framework for the discussion? We make a huge mistake as policymakers, as experts, as press, because we keep talking about healthcare, and we're not actually talking about healthcare. We're talking about healthcare financing. The ACA, Obamacare, the Republican alternative, Medicare for all, those are financing bills. They're about who gets subsidized and who has to pay. We're not actually having structural conversations on what we pay. Think about there's a huge difference there. One is, even the title of part of our discussion today was accessibility on insurance and insurance costs. Insurance functionally is a financing mechanism. It wasn't a discussion on, hey, what technologies, what models have we brought forward that change the price of healthcare? In many ways, we're having the discussion of blockbuster video, of maybe a more efficient drive-through window to get your little DVD than Netflix crashing the price of entertainment in your home, because now you're streaming it into your home. You don't drive to the neighborhood convenience store. I hope that scenario makes sense.
Oh, it does make sense. And, I think that both sides of that about, we're talking about real deliverables in healthcare, versus how this system provides it. And what I see is a system where increasingly Americans are caught in this battle between insurers and providers. And, we see so many Americans. When I did my research on this discussion today, I was shocked to see how many Americans were carrying more than $10,000 or more in health-related debt.
Yes.
And that health-related debt is spread among the vast majority of people who have health insurance. So it just sort of raises, we're not talking about the folks that don't have health insurance. We're talking about folks that are covered and yet are having a hard time struggling. What do we do to sort of begin thinking more holistically, as you just did, and call things what they are? That we have a finance problem in healthcare, and then we have another thing of maybe we need to look at how we're delivering healthcare and revolutionize that.
If I wanted to be a disruptor, and
I do want you to be a disruptor.
I do, and it's one of the reasons why you get the crap kicked out of you daily when you say things like this. But it's true. The first step I would go is legalize technology. You go, huh? The technology exists today for you to have in your home medicine cabinet a thing you can blow into that almost instantly diagnoses you by talking to your phone and saying, hey, you have a virus of this category, or you have a bacterial infection, or you have this. And it could quickly bang off your medical record saying, hey, you're not allergic to this antiviral, and order it. and an hour or two later, Lyft could drop off that antiviral to your house. The cycle time, the fact you have a medical lab in your home medicine cabinet, ideas like that, you could change much of the cost curve because you've removed much of the cost of the system. Except for one small problem, that technology is functioning illegal today in our system. At the state level, the federal level, you've allowed an algorithm to write a prescription. And people say, well, you can't do that. Of course you can do that. You see people with their diabetic sensor and pumps. That's an algorithm, dosing them all day long. There's a number of algorithms that have been approved by the FDA. It's just our structure either says, hey, we only want you got to walk into a facility or do this category of telehealth to get that prescription. You're not going to legalize the reimbursement. You're not going to allow a pharmacy to fill this prescription. So my first thesis is just allow technology to participate in the mix of providing services. And I believe that right there would start the first cost disruption.
One of the things that you also do is you're co-chair of the telehealth caucus. You just talked about telehealth. And in that, this was something that before the pandemic came along, I would say telehealth was kind of on wobbly experimental legs. It certainly had not permeated and become sort of ubiquitous in the healthcare provision system. And that seems to be one of the cases where technology has now been embraced. Hopefully, the reimbursability of health therapy and provision by telehealth will continue. But I guess the question is, what did it take in that case, because you were so involved with it, to bring it there? And so as you're talking about, the screener in your home or other technologies, how can we follow the telehealth path so we can go from an archaic system to something much more modern?
Yeah, and I'm sorry for sounding cranky first thing in the morning, but
no, it's great. I like cranky Schweikert. Okay.
First off, remember, telehealth was one of the most lobbied against technologies in Washington, D.C. I introduced my first telehealth bill a few years ago, and it was never, ever, ever going to get a hearing. And it wasn't until the pandemic hit and we needed something to plug in that our legislation moved forward. The day the pandemic is declared over, so is the expansion of telehealth. It's over. But now's the moment where we've proven that the critics were wrong. They said, well, older Americans don't know how to use FaceTime. They don't know how to, well, it turns out none of that was true. And there's been mass adoption. Now I believe, instead of discussing whether telehealth should be allowed to continue, it's the next level of revolution of telehealth, where it's the thing I wear on my wrist or a tape to my chest or the saliva I put on that's the sensor. And telehealth is more than just FaceTiming, my medical professional. It's the data I can produce off my body, talking to either the algorithm or the healthcare professional. It's okay. So you've built basically the baseline of acceptance on telehealth. Now, what does it look like if part of our goal here is to expand access and crash price? And then we'll get the folks that come in the door and say, well, I'm from rural America and we don't have broadband. Well, okay. We have these things called satellites now, the microsatellites. Every inch of North America now has broadband. But trying to teach people to actually read today's, we're not trying to lay a piece of copper wire to the middle of the Navajo Nation. That was a great idea 30 years ago. Today, we all have Starlink satellites. If we would just put that into our mix of, it's here, but our policy sets are 2 decades out of date.
Another area you've been an active player, and then my friend Congressman Brad Wenstrup, who's involved with the Doctors Caucus in the House, stepped forward, and they really created what was an unusual bipartisan, bicameral piece of legislation. It's sort of one of these unicorns you rarely see anymore. And it had to do with surprise medical billing and the burdens that patients have when they're hit from these, huge zinger costs that come out of nowhere, and how they get resolved. And you applauded this effort. This bill passed. This bill was signed by the president, but it just seems to be chaos since. What's going on?
Okay. You've
Are you cranky?
For a while.
Crankier?
Yeah. The cynicism. Remember, the surprise billing model became a backdoor financing mechanism for very high rates of return, particularly for a certain amount of Wall Street money that moved through the United States, purchasing emergency rooms, certain practices, and the ability to say, hey, you're not in network, so now I get to charge you this insane rate. And then, we'll sue each other, we'll maybe negotiate it down. We came up with a bipartisan, bicameral surprise billing legislation saying, okay, here's the mechanisms, here's the arbitration, here's as a way to get rid of those crushing outliers because you showed up in the wrong emergency room. And then it hits the bureaucracy, the White House, and the agency seems to be drafting language and rule sets that aren't for the bill we passed. It was for previous sort of generations. And my cynicism are the army of lobbyists who are pounding on us here on Capitol Hill that function we're representing venture capital from Wall Street, now pounding on the bureaucracy, because that's the only excuse I can come up with why the rule sets don't actually look like the language.
Pretty fascinating subject. Let me ask you just finally, Congressman, when it comes to the financing, speed bumps, stumbling blocks, Americans are carrying in the healthcare space and just resolving some of this. Do you have any kind of, out of your, left sleeve ideas just to clean this up? I talk about healthcare so much. You and I have had so many great discussions together. It's the one issue I think is so important, but I also wish would go away because things began to get solved. And I'm just interested in what a solution playbook might begin to look like.
You just said something that's absolutely brilliant. And it's the ultimate solution is cures. If 5% of the population is over 50% of the healthcare spending, and you often have some folks throw out the numbers of the end of life, there's actually a real distortion in that. When you get that end of life calculation, that's actually for that individual. The real cost is societal. It's the 5% with multiple chronic conditions that chew up the vast majority of healthcare spending. The most revolutionary thing you and I could do is push, incentivize cures. So the most radical one I will give you, and it's been just wild in my office, the pushback against the idea, which will sound insane, is a cure for diabetes.
Wow.
We know in the field, we've now had, I believe several Americans cured of type 1. Now it's short term. We only have a small data set. It's a stem cell to a pancreatic insulin producing cell technology with a small tag on it, so the body doesn't see it as foreign and want to reject it. But you would have thought instantly Washington, D.C. would have been giddy that we're that close in this technology, and it would have become this decade's functional operation warp speed. Because if diabetes is 33% of all healthcare spending, 31% of all Medicare spending, and Medicare is the primary driver of U.S. debt.
Right.
But I represent a population with the second highest diabetes rate in the world. One of my tribal communities. It's moral, it's compassionate, it's great economics. And it sort of fits what you were just saying, is if we're truly close to curing sickle cell anemia, and you hear the list of things we now know how to do either through stem cell or mRNA, messenger RNA type technologies. Maybe instead of spending our money in a maintenance model, it's now time to say we as Americans are going to fixate on the curative model because that has the long-term benefit of crashing healthcare spend. And it is shocking how the lack of embracing of that idea around here, because it blows up much of the healthcare business model.
Powerful vision, and I appreciate your words and thoughts this morning. Congressman Dave Schweikert of Arizona is ranking member of the Joint Economic Committee. He's co-chair of the Telehealth Caucus, and he always says yes when I call him up, say, let's talk about some cool stuff, even early in the morning. So Congressman Schweikert, thank you so much for joining us.
Thank you for having me.
Joining me now is House Majority Whip Jim Clyburn of South Carolina. He's the third-ranking Democrat in the House of Representatives, and he serves on the Congressional Black Caucus. And he's been a good friend to me in these conversations. Whip Clyburn, let me just start out. I usually don't call out our sponsors on these events, but the sponsor for this is called Consumers for Quality Care. Now, we can call these patients for quality care. We can call it human beings for quality care. And we're sort of looking not just at the economics, but the life dimensions of, a lot of folks have coverage and they're still sinking in debt. A lot of folks don't have coverage. And I want to ask you a political question. What are the political consequences of not actually making real traction in getting this health picture in the country more correct? You're muted, Congressman.
Thank you very much for having me, and I apologize for coming on a little late.
You're always right on time.
Thank you. I don't know that I see any real serious political consequences beyond of a partisan nature. I think that these consequences flow pretty evenly across the board when we fail to solve these problems. I listen very intently when I hear people talk about the failures of certain things that we do and not focus on the successes of them. Now, I noticed a pretty extensive discussion about diabetes. My late wife died from diabetes, 25 years. She struggled with the disease. And I saw what it did to her physically and never thought about it politically until such time as I saw her bill for insulin, which ran from $800 to $1,200 a month. And then I started doing research and found out how long insulin has been around and the cost of making the insulin and how much money could be made by the companies if the insulin was capped at $35 a month. So why was her insulin costing $800 and $1,200 a month? That's where the politics kick in. And so, the political consequences, I don't think are of a partisan nature. It's across the board because everybody here, Democrats and Republicans, independents, everybody here got to ante up the cost of insulin when politically it should not be costing that much. So,
it's not always, the powerful in this, but, I've interviewed in the past our mutual friend Peter Welch, and Peter Welch's late wife, who suffered from cancer, also covered by health insurance, yet staggering costs for various parts of the drugs that she had. And this picture is, just sort of felt across America. Absolutely. in every walk of life. The question is, Congressman, do you have a sense of a roadmap that we need to begin thinking differently about? I'm just wondering, after having done so many healthcare events on access and affordability and Medicaid, and I know you're angry, about those 12 states that are out there that have, left 2 million people uncovered by Medicaid out there. I just want to know if there's a compelling roadmap that can help us change the conversation from your perspective.
I don't know if it will change, being from South Carolina, one of those 12 states. and knowing the history of the country and how regional this problem has been, then I know that the failure to expand Medicaid, basically in those states that have traditionally locked certain aspects of our great country away from certain people. And that I know. And so when you hear me arguing about expanding Medicaid, or in some way, those people who are eligible for Medicaid expansion, asking the federal government to step into the picture and hopefully create another aspect of the Affordable Care Act. Because remember, when we did the Affordable Care Act, we thought we were taking care of all of these matters, and then all of a sudden, we get this decision from the Supreme Court, which kind of laid out a different roadmap for us. And so what we have not been able to do is to make the Affordable Care Act fit the decision of the Supreme Court when it left it up to the states to do certain things that we had hoped we were doing at the federal level, and would not subject people who live in certain states to certain states' rights consequences, which is exactly what it is. You leaving it up to the state whether or not these people of low income who cannot afford certain things, whether or not they get medical attention or not. That's what this decision is all about. So no matter how you cut that Supreme Court decision determining that the Affordable Care Act was in fact constitutional, but it put in that opt-out for states that made it impossible for too many people. That's why I say the politics of it isn't necessarily partisan. The politics is those who have shall get, and those who don't will not.
I mean, this is why you've been out there, I think, very bluntly saying that we have to look at healthcare as a right and change that opt-in and opt-out dimension of it, which I understand. Let me ask you another dimension of this. And again, I'm asking you these big meta questions, and not in a Facebook sense, but like really meta, not the company. But one of the really distressing things that we've all learned as a result of 2 years of COVID, looked at mortality, looked at the level of impact, is that race was a dividing line in terms of outcomes and the experience. Race was a huge issue, particularly early in the pandemic. If you look at diabetes, if you look at rare diseases, if you look at all sorts of other chronic diseases, those patterns are pretty much exactly the same, where there's a disproportionate burden and impact that's based on, at least correlates with race. And I've done zillions of interviews now, and I understand there's an absence of trust, of connectivity, of people seeing folks in the healthcare system that look like themselves. But I'm just interested, you've struggled with this for so many decades. Is there anything that we can really begin doing that we're not doing now to elevate that dimension so that we can make health, at least the healthcare that we have, one that is absorbed in an egalitarian basis in this country?
Well, I noticed the congressman before me talked about getting beyond maintenance to cure. I would start before maintenance and see whether or not there is more that we can do on the prevention side of all of this. Now, we may not know what's caused something like diabetes and that sort of thing, but there are a lot of things on the prevention side that if we were to invest in, it seems to me it would solve some of these problems because they will prevent these problems from ever taking place in a certain place. The environmental issues are very, very important. I remember being at a research institution down in New Mexico several years ago when I was told that life expectancy in this country got beyond 50 in the last generation to where it is now, in large measure because of the water that we drink. If we clean up the water so that people have safe drinking water, we clean up the air so that people will not be breathing polluted air. If we look at the way where we locate certain production facilities and that we know may be causing ill health, maybe asthma in some communities, cancer in other communities. These kind of preventive measures, if we were to do a better job of that, I think that in and of itself would bring healthcare costs down, and it would keep people healthier longer, and they would live a better quality of life. So the prevention stuff, I just don't think that we spend enough time taking a look at what will prevent some of these things from taking place in the first place.
Thank you. Do you think President Biden and his team have a good plan on addressing the cost and debt problems of healthcare? Another thing I learned today, I just didn't know it. You know, basically, you got almost a quarter of Americans with pretty staggering debt that's health related, and these are Americans that are covered by health insurance. And so that's before you get the broad cost of all the stuff you show up at the hospital for next time, but it's the stuff you've already got out there. And I'm just wondering, you know, this is not something I've seen in the headlines. It's not, you know, a topic that I see us having a kind of a daily communication about in this country. Is the Biden team doing enough on it?
Well, I don't think anybody's doing enough. The Biden team has inherited, he's only been there, what, a year and a half now?
Time flies.
Nobody did enough before him or before the person before him. We have not done enough in this area, and we should do more. As developed as we are as a nation, why is it that we lag so far behind the nation just north of us when it comes to health care and its delivery? No, we have not done enough, and we will ever do enough. I don't know. It requires a will that we have not developed in this country to say we are going to do something about this, and we will not let the profit motive keep us from doing it. No, we aren't doing enough.
Let me ask you finally a question before, and then we have a quick question from the audience for you, Congressman. I guess during the Obama administration, I interviewed the Surgeon General, who is Vivek Murthy, and he's back as Surgeon General now in the Biden administration. We talked about the loneliness epidemic in the country. We talked about the mental health epidemic in the country, and we talked about the gun and violence arena as public health issues and public health failures. And so he wrapped all these issues into a health formula. And it made me think back then, particularly on the mental health front, where the economics of supporting mental health, even under the Affordable Care Act, even under, you know, programs that go towards wellness rather than fee for service, of whether or not we really have adopted conceptually a holistic picture of human health and what it means and community health. And, you know, I love the picture. I wonder how we get there.
I wonder about it too. And I do believe that this whole gun violence thing is a problem. It may be mental health in some instances, but once again, it is physical health in other instances. And it's what happens in almost any place in America when you go to emergency rooms and see the proliferation of gunshot wounds and that kind of stuff growing out of a permissiveness that exists and our refusal to be more prevention oriented. And we know from our own experiences in the past what is required to lessen some of these occurrences, but we're not doing it because, once again, the profit motive overwhelms us when it comes to curtailing the presence of guns on the streets of America and doing other things that are necessary to lessen the proliferation of these weapons of war. And we see what's going on. Someone called yesterday and said, maybe it's time for us to have an Emmett Till moment. And I know what that meant, because I know what Emmett Till's open coffin did, even to my own youngest daughter when she saw that. And people are now saying, we just need to see the results. Even what happened in Uvalde there, the stuff that happened there, we have not seen it. We've heard about it, and we are not in touch with it because we haven't seen it. I don't know what it's going to take. I do know this, that there is a will that must be developed if we are going to do anything about these things. Martin Luther King Jr. warned us that the people of ill will was making a much better use of time in this country than the people of goodwill. So the people of goodwill have got to make a much better use of their time to say, what can we do to prevent these occurrences? Stop the violence, stop the absence of health care, do the things that are necessary to improve the quality of life for everybody.
Well, there's a lot you said that's so wise today. I'm going to make sure our team just tweets out what you just said. Martin Luther King's words, very, very important. We have a question for you, sir, from Susan Weinstein, who's the co-executive director of Families for Depression Awareness. Susan? Oh. Well, I guess we have the same way. Let me read it. She says, in mental health, we face a variety of challenges in accessing care, including but not limited to an inadequate number of practitioners and even fewer who meet the demand for culturally appropriate care. Worse, though, is the number of clinicians, especially psychiatrists, who don't accept insurance at all. Are there any federal policy options for addressing this problem, or would it all have to be handled at the state level, such as by making participation in insurance or paying a substantial waiver fee a requirement of professional licensure? So detailed question, but it really is, what do we do about these other gaps of getting folks covered and treated?
She hits the nail on the head. That's what the issue is now. State by state by state by state. We are all Americans. My late friend John Lewis used to say all the time, we may have come over here in different shifts, but we're all in the same boat now. And we may have gotten to these problems in different ways. But to solve these problems, we need a national solution. I should not be able to go to North Carolina and get much better care than I'll get in South Carolina on these kinds of issues. When it comes to mental health issues, when we come to all these other things, there needs to be a comprehensive national approach to solving these problems. People should not be able to forum shop when they're looking for justice, and they ought not be able to go from hospital to hospital to get a quality of health care.
Well, Majority Whip Jim Clyburn, I always love our conversations. I mean, there are some tough ones, but I really appreciate your candor and your thoughtfulness about these. Thanks so much for joining us today.
Well, thank you very much for having me.
It's now time for the sponsor perspective portion of our program. I'd like to introduce Mary Smith, board member for Consumers for Quality Care. Take it away, Mary.
Thank you, Steve, and good afternoon, everyone. I'm Mary Smith, a board member for Consumers for Quality Care. We are excited to be celebrating 5 years as a coalition that is committed to giving a voice to Americans in the healthcare debate. We want to shine a light on what people are experiencing as they seek high-quality, affordable care. I would like to thank everyone for joining this afternoon, especially our esteemed panelists and our moderator, Steve Clemens. We are here today to focus on closing the gaps in health insurance. More Americans are insured today than ever before, yet many are still struggling with rising costs, being saddled with medical debt, and facing challenges finding the care they need, especially mental health care. Public opinion research is an important foundation to everything we do. As we bring together policymakers, physicians, and health experts for a discussion about closing those gaps in healthcare, we would like to highlight the findings of CQC's new poll. I'm pleased to be joined by my fellow CQC board member, Jim Manley. Jim is a seasoned veteran of Capitol Hill. He was spokesperson for Senate Majority Leader Harry Reid and Senator Ted Kennedy, and worked on mental health parity and the Affordable Care Act. Jim will discuss some of the research findings with our pollsters, John Anzalone and Neil Neuhaus. I will turn it over to Jim to get the discussion started.
Thanks, Mary, and thanks to all of you for joining us today. I'm Jim Manley, and I'm pleased to be here with John Anzalone and Neil Neuhaus, two of the nation's top pollsters. two of the best in the business, folks. For the second year in a row, they partnered with CQC to conduct important research into what's on people's minds when it comes to healthcare. Cost has long been a driver in the healthcare debate, as I know from long history on Capitol Hill. Our 2022 CQC poll found that voters are focused squarely on inflation and rising costs as their top concern. What Americans are looking for now more than ever is how to keep money in their pocket, how to get it back into their wallets. That means lowering out-of-pocket healthcare costs and making sure that the care that they do have is the kind of high-quality healthcare that covers everything they need. John Anzalone, as I mentioned earlier, is the founder of Impact Research. John has more than 25 years of experience, including as chief pollster for Joe Biden. He also conducts research for Fortune 500 companies, and like Neil, is one of the leaders in his field. Neil Neuhaus is the partner and co-founder of Public Opinion Strategies. Neil has worked in public opinion research for over 35 years. He's been named Pollster of the Year 3 times by the American Association of Political Consultants and has polled for numerous Republican presidential candidates, including for Mitt Romney's in his 2012 presidential campaign. Like John, Neil is sought out after by the business world and appears frequently as a talking head on nightly news programs and in the major newspapers. Thank you both for being here today.
Thanks, Jim. Thanks for having us.
Yeah, it's always fun being here and going through this with you.
Delighted to hear that, folks. Well, let's just get right into it. Okay, so bottom line, what did your research reveal about the voters' biggest healthcare concerns?
Well, we're seeing a lot of the same things that we've seen over the years that Neil and I have worked on together about healthcare costs, right? I mean, when we ask people top of mind, what's the biggest healthcare cost that concerns them? It's always about, things that they got to take out of their pocket. It's the pain point. It's the deductible. So things that, aren't covered by their insurance. They got to go to the doctor, they pay something. They go to, a hospital or emergency room, they pay something. They, out of pocket costs are kind of how they think of it as being nickeled and dimed. They have insurance, but they're not covered. And that bothers them a lot.
Well, speaking of increasing, looking through the polling, the research also shows that medical debt is seriously affecting a majority of the households. Can you expand on some of that polling as well?
Yeah, let me tackle that one first and then turn it over to John. This was really interesting, and we haven't really tested this previously, but we asked voters if the medical bills had seriously affected their household incomes, their daily lives, them or someone they knew. 25% of the voters we talked to said it impacted them. 28% said they know someone who had been impacted. 53% total know someone whose household finances have been impacted by this. And the most incredible 2/3 of those say that they know somebody who has had a medical bill go into collections. I mean, more than half of these people say that the amount of a bill that went into collection was at least $2,500.
And when you kind of drill down to vulnerable populations, right? For example, we, had a category of people who are just struggling to make ends meet. 80% of those households who are struggling to make ends meet had medical debt, right? And I think 80% or more of Black families. And so again, that number jumps from 53 to 80% in certain universes, which is at that point, it's a pandemic problem.
Well, thanks for that. Okay, again, as was alluded to, mental health. So on the one hand, we've made some pretty significant strides in mental health parity over the years. It hasn't always been easy. It took a while, but we've made a lot of progress. But it's still a major issue, especially now in light of the pandemic in particular. What looking at the research, what does the research say about Americans' ability to access mental health care?
It's a real problem. Again, you said it during the pandemic. We're in our third year. We know that there's a lot of mental health issues that are a byproduct of the pandemic for many, many reasons. And 57% in this poll says that it is difficult to find medical health providers that are affordable and covered by insurance.
I think everyone can agree that reducing healthcare costs, would make a strong part of a plank or strong part of a platform for candidates up for re-election in November. So my question is, what do you think would help move the needle on, the issue of high healthcare costs?
When candidates talk about it, our data indicates that capping insurance deductibles, capping the amount that health insurers can make patients pay for, out-of-pocket costs, requiring PBMs to pass along rebates and discounts to patients. Those kinds of things resonate with voters, and they think that will make a difference in lowering their own healthcare costs.
And I think that one mistake that candidates may make, quite frankly, in this kind of inflationary economic environment is that before inflation was at this levels, we would ask what's the top economic concern, and healthcare would always be the number one issue, right? Because it was a pain point. Now, without a doubt, is gas prices, food prices, et cetera. But that doesn't mean that healthcare costs aren't important, right? When we isolate it, we see how intense and that a majority of people believe that it's a major concern, and they feel that their deductibles and their insurance premiums are going up. So it's an issue. It's maybe overshadowed by gas prices and food prices, and to a growing extent, housing. But it shouldn't be in any way dismissed.
Yeah,
I'm hoping, truthfully, John, that we're no longer going to be campaigning either for or against the Obamacare in this election.
Yeah.
Add my voice
the first one
as well.
For the first time in a decade.
Yeah, well, all very good points. And thanks for clarifying on my last question. So, well, again, John and Neil, thanks so much for conducting the research and sharing your insights. And on behalf of CQC, we appreciate it very much.
Thanks, Jim. Thanks for your work.
Yeah, it's been a pleasure. Thank you.
Thank you.
Thank you, John, Neil, and Jim. To learn more about the research, visit www.consumers4qualitycare.org/research. Thank you again and enjoy the program.
Thanks again to Consumers for Quality Care for supporting today's important conversations. A record number of Americans have health insurance, yet quality, affordable care continues to be a major concern. And joining me now to discuss what it will take to close these gaps in ways that are both effective and equitable, it's just a fantastic panel. Dr. Donna Christensen is a former member of Congress. She chaired the Congressional Black Caucus Health Brain Trust for 16 years. I feel like I talked to her a few years ago just as she was in there. And I love knowing that there's a Black Caucus Health Brain Trust, and she ran it there. She currently serves as a board member of Consumers for Quality Care, the sponsor of today's event. Amy Hinojosa is president and CEO of MANA. If I'm getting it right, M-A-N-A, MANA, a national Latino organization that builds multicultural collaborative networks to advance equity. And Dr. Sarah Collins, who's an economist and vice president for healthcare coverage and access at the Commonwealth Fund. And for those of you who haven't followed the Commonwealth Fund, they're like the kind of Wizard of Oz of health stuff. I mean, you kind of an amazing kind of global awareness, data, statistics, what's happening on healthcare around not just the United States, but the world. So thank you so much for being with us. Representative Christensen, it's such a pleasure to see you here and to be with you today. And look, I want today's conversations to really matter in a way where we're not just kind of lamenting again all of the gaps and mistakes. Part of it is an awareness of what's not working right. But I'd just love to hear from you, given your long experience, on the side of decision makers, those who are voting on policy. What can civil society, what can our friends Amy and Sarah and others out here do to try to enhance the efficaciousness, if you will, the effectiveness of the policy world on these questions? You're on mute, Donna.
Here I am.
Oh,
Okay.
there you are. Great.
Yeah, I think exactly what they're doing. They are provide the Commonwealth, which I've worked with when I was in Congress. We attended many of their sessions. Provides a vast amount of information that and they provide it to members of Congress and other policymakers. And in Amy's case, MANA is a strong advocate, not only for healthcare, but for all of the things that make up the social determinants of health. So I think we just have to keep doing what we're doing. But I think that they're doing their part, and we just need to keep beating the drum.
So let me ask you another question before I move to the others, Donna. You know, one of the terrains that we've been discussing is the huge levels of medical debt that insured Americans are carrying. It's just something I haven't seen discussed much of, and it's very, very substantial. Now, I know the Biden administration are coming into work like with 500,000 Americans. That's, you know, sounds like a big number. It's not in terms of erasing, you know, some medical debt at that level. But I guess the question is, who's the, you know, not to say that everyone has black hats and white hats, but who's the villain in the medical debt story?
Well, you know, CQC has been really looking at the insurance companies. As I think someone said in the previous panel, the consumer, the patients feel like they're being nickel and dime by the insurance companies because of the ever increasing cost of their out-of-pocket spending. And so that's one. We also look very closely at hospitals and whether they're being transparent, or how much they're charging. Are they utilizing their tax credits to provide charity care? And we look at medication as well. We've been very supportive of some of the legislation to reduce the cost of insulin, which Jim Clyburn mentioned when he was on. So it's a myriad of things, but we have been focusing on the problems that insurance companies and hospitals, for the most part, have been causing.
Thank you so much. Sarah Collins, you know, I'm really, really happy you're here. And maybe you can tell our folks, too, where folks can reach the incredible amounts of data and research. I feel like I've been reading Commonwealth Fund reports forever. But we do have a question I want to start with. It's from Pinal Patel, who's a consultant with Botgio LLC. And she says, has the uninsured population in the United States actually increased or decreased from January 2020 to January 22? And what's attributed, if anything, to a shift? So I think it's an innocent question, and I don't know the answer to it. Do we have more uninsured people today than we did 2 years ago?
Actually, you know, it was widely expected that the number of uninsured people would rise because of the pandemic as people lost job-based coverage. And what we've seen actually is that the uninsured rate has actually declined from a pandemic high of 12.3% to about 10.5%. So there's been an improvement actually in insurance coverage, and that is because people who did lose their coverage had the Affordable Care Act safety net to get covered through the marketplaces and through Medicaid. And the other reason is that we saw a major increase in the subsidies for marketplace plans that improved the affordability of those plans and led to record enrollment in the marketplaces. And then another factor was the continuous enrollment provision in the Families First Coronavirus Response Act that required states, in exchange for a federal increase in the federal matching rate, to keep people enrolled continuously in Medicaid over that time period. So we saw record enrollment in Medicaid and the marketplaces, and a decline actually in the uninsured rate.
Sarah, you know, one of the areas that I've been wondering in is my own insurance seems to be changing every year. I have other people in this world. Is all insurance just insurance, or, you know, is there an unevenness out in the insurance world? Are there sharks or areas of concern out in the insurance world? Can you just paint a picture of how wobbly or secure our insurance coverage is in America?
You know, we've made really big strides in making sure that people's health plans are comprehensive, that they are affordable. But there is a lot of work still to do. We know in employer coverage that people's premiums and deductibles over the last 10 years have risen much more quickly than their incomes, which means that cost burden is growing in their budgets. We also know that people, and we've talked about this, people have out-of-pocket costs that are high relative to their income. So even people who have insurance coverage all year have difficulty affording their health care. Why is it that a third of people in private insurance plans struggle with medical bills and debt, even though they are covered with comprehensive coverage? And we really need to start focusing in a policy way, in a very focused policy way of looking at what the drivers are of this and why people are ending up with these big bills.
Thank you. Amy, I want to ask you about what some of the fault lines and cracks are in the healthcare system from your perspective. But we've got another question. I just might as well start with it from Teresa Martin of the Certified Diabetes Care and Education. She's a specialist there. What prevents payers from following evidence-based care is the question. Prior authorization interferes with quality. Why not demand prior authorization for non-evidence-based care? I have no idea what the answer to this question, but what I do know is that there are a lot of folks that look at the prior authorization world as another speed bump in this process that adds costs, that diminishes access, and gets in the way of this. And I'm just interested from your perspective as you're working with the Latina community, is this an issue for you, and what are your thoughts? You're on mute. There you go.
Okay, yeah. Great. So, what we're really looking at when we're talking, this goes to the heart of access to care, right? And even if you have access to care, do you understand the information that's being given to you? Is it being given to you in a way that you understand?
I don't. I don't. I mean, in my own case, I'm just going to have I don't even understand. So go ahead.
And you're absolutely right. So then when you add the layers, maybe an undereducated level, when you add a cultural level, when you add a linguistic level, right? So there are multiple barriers that are already keeping folks from even understanding the advice that's given to them. And that's assuming that they have care in the first place, right? As Sarah mentioned, with the ACA, we've gone so far in being able to get folks covered, but we still have 30 million people, whether they're people of color, from underrepresented poor communities, who are still uninsured. And so even that barrier of access to care, we're just not even getting to that point. And I think when we have these conversations about access, we have to talk about who are we not reaching, right? And then what are the capabilities beyond that for them to even be able to have a conversation about what they should be doing in terms of their own healthcare decisions.
So what's the answer to that? Do you need to have greater uniformity in the provision of healthcare out there? Because it occurs to me, and I don't know Mana that well, and I promise you after this show, I'm going to dive in and, we're going to know each other for a long time and get to know, a lot more. But does Mana, has it thought about, helping to think about concierge services for the community you provide so that they have a place to go to help become more literate on these questions or issues? Is that too much of a burden? I mean, part of patient advocacy is actually helping to enhance their literacy in these issues, like you've said. But without an infrastructure out there, without folks to talk to, I'm not sure how you do it.
And that's such an interesting question. And this is the role that the federal government can play here, right? Because we've all heard of programs that provide funding to local communities to help with these types of things, right? Community serving, health organizations. But unfortunately, that funding isn't continual. So it's not considered something that is sustainable, right? So communities often have to take it upon themselves to fund community health centers that serve their communities, and then finding the healthcare professionals and the staff who are linguistically competent, culturally competent to be able to provide these services. But, the truth is that if you're someone who doesn't have access to care, oftentimes your first interaction with the medical community is going to be in an emergency room when you need critical care, and they may not have those wraparound and support services to even serve you properly.
Yeah, and I've been reading those emergency room costs are a huge, huge portion of this carried debt that people have, even if they have insurance. That if you look at how that debt is broken out, where it came out, it's these emergency room moments. And we've discussed some of that earlier in the program. Donna, I know that the Consumers for Quality Care and the board and your own work have looked a little bit at the kind of junk insurance industry. And could you tell us more about it?
Yes, and that's one of the reasons why people are finding themselves in medical debt and with high costs that were unexpected, because those are insurances that I consider them junk insurance plans, really, because they don't provide all of the basic cover benefits that should be provided. And when someone gets sick and they think that they are covered, they find that the insurance that they have just will not pay for the services that they needed. So yes, it's one of the issues that we have been very active on, and we've written to CMS and other, and also in op-eds about banning those short-term insurance plans and other junk plans. And actually, that's one of the things that the survey said needs to happen to lower the costs to them, lower their out-of-pocket costs.
Thank you. Sarah, you know, one of the basic political sensitivities in Washington right now, you know, we don't want to get into the whole big thing, but you know, you've got Senator Joe Manchin on, you know, wherever the senator may be with regards to Build Back Better, but he says, look, we need to kind of help people where they're really at. We need to negotiate lower drug prices. We need to basically, you know, enhance that. It's one of its highest agenda items in that. I'm interested in whether that element of a program translates into lower healthcare costs that people feel over time. And are there other things in terms of dealing with people in their pocketbooks that should also be on that agenda?
No, I think that's exactly where we should be looking. We are not looking as critically enough at prices, both drug prices, but also prices that hospitals charge insurance companies in commercial insurance markets. So this is a critical driver of healthcare spending. Premiums are driven by overall growth in healthcare costs, and the primary driver of healthcare costs are the prices that we pay to providers. So this is a very important part of the conversation. If we want to expand, for example, extend the marketplace subsidies, and Congress can do this, there is a cost attached to that. But we need to look at what that cost is. And that cost is driven by the prices that we pay for our services. It's not utilization, it is mostly prices. And so this definitely needs to be part of the conversation as we consider ways to address universal coverage, to get more people covered. But the prices are a very important part of that conversation.
Amy, I'm going to give you the last word, and you know, I'm going to make this a tough question for you. I'm always interested in like stories that can be replicated or they, and I guess my whole goal in having these conversations with people is to find a day or a way where patients become their agents, have agency in their story, and they're not just victims, you know, and you're either gonna, you know, surf the wave or get clobbered by the wave. Are you able to share with us any vignettes of a story where you've been able to empower Latina women in a way where they were able to go from being victims to surfing their wave and in control?
You know, Steve, this is so nice to be able to have this conversation, because we think that's absolutely the model of what MANA does. So we have chapters and affiliates across the country, women who are engaged in their community, who are trusted community leaders, trusted sources of information, and their entire mission is to make sure that they're sharing information and resources, exactly that, so that women have their own trusted sources, they have their own information, and then they have their own agency to make the decisions that they want based on the information that they have and that's available to them, and that they understand in their own language, in their own culture. And so, you know, I think that to answer your question, MANA is the solution, right? And having women in the community who are trusted by other women to share that information and make sure that they're getting what they need, right? And because everyone thinks of things from such a personal level, you know, when we talk about can folks pay out of pocket expenses and who's being hurt here, right? So 1 in 5 Latinas live in poverty in retirement. You know, if the average, you know, Social Security for women is $14,000 a year, for Latinas, it's $12,000 a year. And so, you know, when we talk about formularies and how, you know, decisions can be made around pricing, these are decisions that leave these folks out of the conversation. So in addition to that work being done at the local level and at the community level, what we do out of my office here in Washington is advocate for those policies here in Washington that help these women navigate these waters and to make policies that take them into account. And this is why we work with the Consumers for Quality Care. We work with the Health Equity Collaborative to make sure that we're raising these voices so that the answers are equitable across the board and that communities all across the board are able to get the services and the information that they need and the care ultimately that they need to live healthy lives.
Thank you. What a great conversation. I look, for better or worse, this is a perennial issue. We're going to keep covering this. My colleagues at the Hill are going to keep these discussions going. Hopefully they'll let me come back and play with all of you again. I would love to keep this conversation going. A big thank you to our panelists, Dr. Donna Christensen, a former chair of the Congressional Black Caucus Health Brain Trust, Amy Neuhaus, President and CEO of MANA, and Dr. Sarah Collins, Economist and Vice President for Healthcare Coverage and Access at the Commonwealth Fund. That brings us to the end of our program today. A very big thank you to Consumers for Quality Care for their support and to all of you attendees for joining us for this discussion. For those of you who may have missed any of the conversations, video from the event will be up on our website shortly. I'm Steve Clemens. Be well.